of the Center of Clinical Neuroplasticity, Medical Park, Ludwig-Beschweinstein, University of Erlangen in Germany. We heard his excellent presentation in the morning, and today he will be talking about living closer to life without MS.
All right, getting closer to life without MS. This is, I guess, what we are all aiming for. And even though we don't have a cure, but we would like to introduce and maintain long-term remission. This is definitely a goal, and this is probably necessary that we have treatments which work on both sides in the circulating immune system, but also, as I mentioned earlier, beyond the blood-brain barrier. So a small molecule like Mavenclad, for example, which is known to transmigrate into the central nervous system at doses which are effective, is highly effective in terms of immune reconstitution therapy. It bundles three different benefits. Compared, on the one hand, it's strong in protection against relapse and disability progression with onset of action in less than 1 month. It is sustained with high efficacy beyond the active dosing period for at least 4 years. And this is, I think, something we had to get used to give a medication, it's pulse treatment with only 20 days over a 2 years period of time, but can have an effect lasting even longer. And that tells us this is going beyond just dampening cells, but it has something to do with the re-education of the immune system. Therefore, it's called immune reconstitution therapy. And it's simple in terms of dosing, monitoring, family planning, opportunities, and vaccines can be administered, including the currently approved CD19 anti-COVID vaccines. So Mavenclad, as I alluded to, is given at rare intervals, 4 to 5 days, depending on the body weight, the first month, then the second month, and then in the next year, again, within the first month and the second month. So overall, you can deliver high efficacy across all relevant clinical and radiological endpoints with a maximum of 20 days of oral dosing within this first 2 years, by a reduction of annualized relapse rate by 57.6%, 47% reduction in EDSS progression, reduction in T1 gadolinium lesions by 85%, and reduction T2 lesion by 73%. And this is on the overall population, and we even have seen effectiveness to a greater extent in the population with high disease activity. It also maintains stability, leaving 9 out of 10 patients free of disability progression over the period of 2 years. We do have data on the MRI, inflammatory brain lesion activity. Again, 9 out of 10 patients remain free of inflammatory brain activity for 2 years, and this is reflected by the high reduction in T1 gut lesion, so standard aspects of reduction in active T2 lesion, as well as the effectiveness on the reduction of combined unique activity lesion. And then, of course, we're trying to maintain a status of no evidence of disease activity. And compared to the placebo group, in which it was obtained in 17% of patients, nearly 47% of patients reached this status after 2 years. That means approximately 1 out of 2 patients can maintain stability. And if you look across various clinical trials, you can see here the one which is in orange is the Clarity trial, compared, for example, to the left with the 2 ocrelizumab trials. These are very highly effective drugs maintaining neither 3 state in the population of being treated. And that is something, as I mentioned earlier, what we really want to achieve first in order to allow the central nervous system to recover, to maintain the reserve, to induce plasticity, to really cut down and shut down the inflammatory aspects of the disease. I would like to give you some data on observational study now, which is rather new, using the MS-based registry, one of the largest compilation of patients who have been under different kinds of treatment from different countries across the world. And it allows us to do comparison trials, propensity score matching of patients who have similar aspects of the disease in terms of age, evolution of the disease, sex, different prior kind of treatments, and then compare it to the treatment you're focusing at. And with this, many studies have been done, and I will just focus on the first results, which have been done of comparison of patients who are on Mavenclad compared to by propensity score matching similar patients who had been on different medication. And here are the results. For example, if you do this approach to patients who have been either treated with Mavenclad or fingolimod, there's a significant increase of the patients in terms of reduction, again, the analyzed relapse rate. And it also has shown that the approach to the occurrence of first relapse while under treatment, patients remained stable over time, much higher to an extent already seen this curve going down in patients with fingolimod. So that means they are then earlier in the list of requiring new activity than patients who are at this stage still receiving the second part of treatment, but here they are no receiving any further treatment and still maintained a high number of patients who are without further disease activity in terms of the relapse count. If we look at this one here now, a similar comparison were done with dimethyl fumarate. Again, a 35% reduction comparing these two compounds in favor of Mavenclad. And also here already a little earlier, a split of these two curves, and the likelihood of patient remaining relapse-free is all over the time higher on a patient with Mavenclad compared to dimethyl fumarate. So I haven't mentioned the various numbers of patients which were included here, 450, in each of the groups in this individual comparison of propensity matching. Looking at teriflunomide, for example, here we have a comparison of 458 patients, and we have a reduction by 48% in favor again of Mavenclad compared to teriflunomide in terms of the analyzed relapse rate. And on the right side, the time to first relapse also is much earlier achieved in the teriflunomide group, and stability here right from the beginning in patients on Mavenclad. So if we compare these aspects in the GLIMS real-world registry study, Mavenclad showed significantly better real-world effectiveness for the analyzed relapse rate, the time to first relapse, as well as treatment persistence versus fingolimod, dimethyl fumarate, and teriflunomide. And again, be reminded, Mavenclad in this comparison is the only pulse therapy medication compared to continuously given medication like the three ones which I just mentioned. And now we have the great honor, we're coming back to face-to-face meeting, do a team meeting now, because even though I have done several visits to Rashid Hospital, and we're also long-term attached to this hospital, it's my great honor now to hand over the microphone to Dr. Reem Al-Suwaidi, who will give you the results from the Mavenclad cohort here collected and the data they have achieved over the last couple of years at Rashid Hospital. Please.
First, put the mic down. Thank you. Okay, so I'll be presenting our sample data from Rashid Hospital. We have more than 60 patients actually on Mavenclad, but we have the data only for 42 patients. Most of our patients are switcher. We have from fingolimod, dimethyl fumarate, and other medication, and we still have 25% as a naive patient. What are the reasons of switching? The main reason is disease activity, and others are intolerable side effect, or as we know, pregnancy planning, or converting to JC virus positive. With Mavenclad, we have more than 96% adherence to treatment. You can see the numbers? Okay. So at year 3, more than 40% of our patients are almost completing the 2 years of medication, and they are going into year 3 of a treatment where they don't need to be on medication. The same data, 9 of 10 patients, the same as what Dr. Peter presented, are free of relapse, mainly at year 2, 3 of treatment course. Most of our patients, 9 out of 10 as well, are either have improved in their EDSS or they are stable on the same EDSS. Almost 9 out of 10. So you will hear this number frequently said, does not have any new T2 lesion or any T1 GAD enhancing lesion on their follow-up MRIs. What are the side effects? These are the main thing that we need to know when we are starting patient medication. So the same as the published data, no major side effect. We did not have any grade 3 or 4 lymphopenia. The most presented side effect is the upper respiratory tract infection, was less than 5%. So in summary, 9 out of 10. No MRI lesion, no new lesion. They are free of relapse. They have stable or improved EDSS. It's well-tolerable medication from our data with no major side effect. And as we said, no grade 3 or 4 lymphopenia, and with a compliance rate more than 96%. Thank you.
Okay, thank you, Dr. Riem. Nice presentation. Thank you, Professor Rieckmann. So any questions on the last two presentations?
Thank you. Dr. Rieckmann, we all know the pros and cons of real-world evidence and MS base, and they try to match patients and all this. In the trial you presented with glimpse, in the fine print there, it says there's a dropout of patients and no explanation was given for the dropout of patients. Is it really a good idea to share this kind of information when the authors of the study can't be bothered to tell us why there was a dropout of patients?
The problem is in terms of all these comparisons we do across this one. These are facts because these are real world data which you can't account for. So you have to look at the differences at the time given and the number of patients which are still remained in there. This is what we know. And this is the data which we have at the moment for the first type of real world evidence. And this is approach which is being done in different studies, but we know that this is a limitation to this kind of approach, yes.
The dropout in patients, was it similar between the Mavenclad and the non-Mavenclad groups?
Yeah. Now, the problem here really is that Mavenclad is given first year and the second year, and then there's no further medication given. So if they drop out of treatment, this is not what you measure in a different way than there is given continuously. That's what I've mentioned at the end of my talk. So this is one of the main differences of the treatment approach in general. If you have a medication which you give continuously, or if you give a medication which you give just in pulse intervals, that's a difference we have to take into consideration. But something which is of interest definitely is that the effect, for example, real world data you just have heard from Riem presented here at the Rashid Hospital. We have also finished a cohort of patients who completed the 4-year follow-up at our center and similar data from other centers in Germany, which were almost identical to what you just have heard. You can maintain 9 out of 10 stability. You get the 60% stability or 30% even improvement in patient over that period of time. Again, with only 2 years of treatment data. I think what our view on medication is that there's all this, we know this, drugs don't work and people who don't take them, we have to think in a different way now. We're using something which does not require a quantitative drop in lymphocytes. You see the lymphocyte values here are just normal or even slightly below normal values, but it's the qualitative change which happens to the immune system in order introducing a different kind of immune reaction which maintains for a longer period of time. And that's what is behind this concept of immune reconstitution therapy.
Thank you, Professor Rieckmann. A question here before Dr. Ali. When would you repeat cladribine cycle after 2 years?
Sorry, again?
When would you repeat cladribine cycle after 2 years?
So that is a big question, and there have already been consensus statement on when it is, when it is necessary, or how will you organize basically the follow-up, because the patient are not on treatment. So you what we call breakthrough disease, is recurrence of disease in terms of the patient population which are being followed up. So the consensus statement on that is, we know that in some patients, the first year of treatment will not completely show its effect because it's 3.5 milligram per kilogram body weight, so you have to do the complete dose. So if some minor relapse occurs, you just get the second year of treatment. If then later on minor relapses can occur, it is possible, also from the safety side of view, to give another course, for example, in year 3 or year 4. But this is hardly necessary. Also, the one we have over 5,600 patients now, and it was only, I think, in 20 which had a third course of treatment or third year treatment in the overall German population. The question is, what will you do after 4 years? Because that is covered with the Clarity extension trial. And that depends, of course, if there is reoccurrence of disease activity. It can be used. It's based on the approval for 4 years, and 5 or 6 years treatment is possible. And it has to be shown for the long-term follow-up now whether this is necessary or not.
Thank you, Mr. Rieckmann. Last short question.
So I'm happy with the 9, but I want to talk about the 1. Do I have any biomarker in the non-responder, which mean if the patient is not responding, his lymphocyte is not changing at all? This indicates that this patient is non-responder and he may have relapses, not responding to the second year after 4 years. Because we have this experience in 1 or 2 patients in UAE, so with the non-responder, but the lymphocyte does not change at all after a phase or second course.
Can you summarize the question in 1 word?
Is non-responder to Mavenclad. The patient who not respond. Is this correlated with the response of the lymphocyte after giving the medication?
All right. Okay. Yeah. Right. So, right. So again, as I mentioned, the collection of lymphocyte data, which is required as monitoring at month 3 and 7, is only to see for the safety aspects. It's not necessary in terms of the effectiveness of treatment. We know that in the patient who had low lymphocyte count, some of them dropped further. There is a slight risk. I didn't put the safety data to, or a greater risk to have, for example, varicella zoster. Localized though, but this has occurred and correlated with lower numbers. So it's only for safety, not the effectiveness. Is related to a significant drop in lymphocyte. And that's again what I mentioned. It's not about the quantitative change, but about the qualitative change of the type of lymphocytes which come back. And there are some immunological studies which have already shown this, and still something which is ongoing.
Thank you.
Okay, we're finished, but because of Dr. Yasmin, we'll ask.
It's a brief question. So regarding women in childbearing period, the safety profile of Mavenclad, if pregnancy happens in the first 6 months, what's your opinion on that?
You mentioning a very important aspect. You know, usually we have patient at a young age, female with childbearing age, and patients who are highly active. If you start a treatment, it comes to the question, when shall I stop the treatment if I want to get pregnant? Here it's different. You start with the treatment and you know that after the second year treatment, another 6 month safety interval, you can get pregnant while still perceiving the effect of treatments, even though you don't no longer take it. And this, of course, is a much better situation for a woman, not to be fearful, you know, now I stop my treatment, now I need to get pregnant. This is stress. And this one is not necessary here because you can, again, perceive the effect of treatment after that period of time, but can get safely pregnant at month 18 of the second year, and then continue for 2 other years of potential disease-free state.
Thank you, Professor Rieckmann. Thank you, Dr. Riem. Dr. Yazia has some